I'd like to introduce to you Bonnie Slavich, who is a doctoral student in this is impressive, the Arkansas Consortium for a PhD in Communication Sciences and Disorders. That's pretty new, actually, around here, isn't it? She presented on communication disabilities and aging during the 2014 Summer Institute Training for Faculty. And I'm going to turn this over to her.
Hello, good afternoon now. My name is Bonnie, and Dr. Atcherson was talking about how as we age, we start losing some of our hearing, right? And he mentioned that one group of people in particular he worries about, and those are the ones who are in the assisted living facilities. Okay, I work primarily in a skilled nursing facility or a long-term care facility. Any kind of examples that I have and we talk about today are going to be drawn largely from there. But I really want to make certain, I hope that I can get across, for this group of people, their lives have changed so much. Many of them feel that they have lost so much, and it's really hard if you go in there to see the tears, everything. And that's what I really want to impart today, is the feeling of it all, the quality of life that we can work together to help maintain for them the higher quality of life. Are you nurses, therapists, nursing? Mm-hmm. The largest group of professionals that we work with. We have a team of 9 at my facility, 9 therapists. We started out with just 1. It's really grown over the last year, and nurses and CNAs, that's who I work with primarily. I do have a physician who comes in once a week, and of course his nurses that we deal with. So this will be, I think, really good for us to talk through to see what we can do to work better together so that we can serve these people in the capacity that they most need. All right, so I'm going to talk about communication disability and aging. There is a voice component to this. One thing I don't want to lose, though, is the cognitive component. So we'll have some information in here based on that. So the U.S. Bureau of the Census in 2010 said that about 1 in 8 Americans is 65 years and older. Well, in 2011, the oldest of our baby boom generation started turning 65. So what does that mean for us now? 2014, 2015, 2016. We're going to see what? Look at this. Here back in the, early 1900s? This is our 65 and over population right here, right? It's progressively what?
Increasing.
It is. And then right here we have our older group, the 85 and older. And look, right here about 1970, we can see it start doing to what? Increasing as well. So, and look, this ends at 2050. That's what the U.S. Department of Bureau projected out to is 2050. And they said the way that from our birth, death rates, everything that we expect to happen, we're looking at getting up in 2050. My pen light is going out, but look how high we're getting up in the millions, 80 million. So what is that telling you? What do you expect your group of patients to be? Older. So, and what do you need to know then? How do they differ from the younger people, right? So let's see what we can find out here. Now, we're in Arkansas. Arkansas is what kind of country? Or what kind of state? Rural. That's where your older people live, right? That's just the way it has been. But right about where Arkansas is, you can see right there, 20 to 34.5% by county. We're high up in there. Those are the people that we are serving. All right, so before we get into it all, treatment and everything, we'll talk real quick about Lubinsky in 1997. He put aside or made these real nice, clever bullets stating these are our roles for communication. I'm going to give you a minute to look at those. All right, we never really think of it, do we? Each one of these things that hey, we need to be able to communicate so that we can change according to our situation, right? Or that we can be decision makers for ourselves. We don't think about that because we don't have those problems typically, our age group, in these roles. It's part of what we do. It's part of who we are. There's nobody questioning our autonomy, right? Our independence, okay? So think about these and how they apply then to the older people. Now, we'll continue. With the number or group of people getting older and the sheer numbers that they're projecting, these are the clinical challenges that we're going to face even more so now and in the future. And these are diseases that we often see. ALS maybe not as much, but it's still something that you've all heard about, right? I've had 2 family members diagnosed with ALS. Very debilitating disease, very quick to end a life. Changes, not just for them, but for their family members. All right, so as we age, these are our system components that might affect our communication. We've got the cognition and language, hearing, which Dr. Atcherson just spoke about, speech, and voice. But all 4 of these, we as professionals in the healthcare industry have to consider with each person who's coming in, right? So let's go through each one. Now, Dr. Atcherson talked about reduced auditory processing speed, right? What is that phenomenon that you feel when you know what you want to say, but you just can't say it? You just can't get it out. What is that? Right there it's on the tip of my tongue, right? We all have it occasionally. Our older people often have it more, right? So they're feeling that tip of the tongue phenomenon more frequently than we are. Combine that with reduced processing speed, which is going to happen as we age. So we have those 2 things working against us already. That means that for our older person, they're going to start having difficulties with processing complex sentence structure. So now let's apply it to those who are not only going through the natural age-related changes, but then find that they're compromised, their health is compromised. What do you expect to happen for those people when they're in the room with the doctor? The nurse is asking them questions. The CNAs have questions. The therapists are telling them to do things. It'd be too much, right? Are they going to be able to process and remember everything and understand exactly what is said? So put this, then let's translate this into a very practical situation. You go into your patient's room and you come out just speaking to them as I'm speaking to you. You're asking them a question maybe. If they need something about their medication, something they may have been reported overnight that happened, and you're asking them to elaborate. Are they going to be able to get across what they need to you, or even understand what it is you're trying to figure out? That's what you're dealing with for these people in these facilities. So what you're going to find basically is that your patient may talk more but say less. It means less. They're just talking. I've got one right now. So, all right, let's move forward. Now, Dr. Atcherson talked about hearing. I want to tell y'all about a situation I ran into just several weeks ago. I was called into a facility. I was asked to look at a patient to see if she needed any. I'm a speech language pathologist, so see if she needed any speech services. And everybody's saying, no, she can talk just fine. It's not all we do. I went through her chart, and the first page said that she answers questions just fine. All they have to do is she can talk. The nursing can talk back to her. They can find out exactly what they need to know, no problems. So I went in there with my standard evaluation, expecting everything to be good. Wasn't long before I realized that she was responding based on the way I was asking questions. If I nodded my head, she nodded. If I shook my head no, she shook her head no. If I ended my sentence with okay, she would respond okay. So I started asking more difficult questions. First couple of times she would ask me to repeat myself, or what did you say? Would try again. As the questions became longer, or my statements became longer and more complex, I saw her just kind of sit back, look out the window. She was withdrawing from me. Okay. So think about some of the things you have to say to your patients or ask them. And if you're not really aware of their hearing status, and if you're not careful with the way you move when you're with that patient, you're going to think what? That they understand everything you're saying, right? That they understand the directions that you're giving to them. When in fact, they might not want to tell you they have a hearing problem. Or they might not think to tell you that. Might be, what else? What else would keep somebody from telling you they have a hearing problem? Or that they can't hear what you're saying? Or that they don't understand what you're saying? How would you feel in that situation? Maybe some embarrassment. You know, I've always been able to care for myself, make my own decisions. You know, I've always understood directions that I've been told. So that person might not want to admit that he doesn't understand everything you're saying. So what do you think the simple fix to that is? Before we get into whether or not she needed services. Just based on the hearing, her inability to hear everything I was saying.
Speak slower.
Okay, you can speak slower. He talked about speaking slower and more clearly. As a speech language pathologist, there's something else I've got to think about. I've got to think about all the nurses and CNAs and physicians and everybody who might be walking in there later. And what can I do to help them get through what they need to with this lady, with her still feeling as independent as possible, being able to make as many of her own decisions as she can. But I can't possibly, you know, some of us just talk faster. You may not have time, right? The 60 minutes that I had, you may not have that. So there's another real simple thing you can do. You can take a piece of paper and a pen. No speech therapy needed for that. Just gotta educate. This is all you have to do. And guess what? When I broke out that paper and pen and I wrote down my first question, she grinned. She was so happy. So then all that was necessary was for me to let nursing know, hey, just go in there and write it down. Get a whiteboard and a dry erase marker. Okay? But, and here we're talking about that quality of life again. So as we're aging, we have slower or reduced processing speed, more difficulty maybe hearing, but there are things that we can do that while we're still they're dealing with this, they can still feel that they're retaining their independence. Now we're looking at, also with aging, other diseases that can affect communication. Nervous system dysfunction, respiratory dysfunction, laryngeal dysfunction, which we'll talk about. Then, of course, we've already mentioned the hearing loss and other sensory changes that we'll talk about for just a moment here in just a little bit. So these are your speech and voice, or your subsystems for speech and voice. Some textbooks will tell you there are only 3, some will say 4. I've thrown them all in here for you and found this little graphic that I like. And we're going to start right down here with respiration. What is respiration? Exactly. We're breathing. And where does that come from? Or what do we use for that? Yes, we use it to stay alive, but I mean, what organs? The lungs. All right. So, in order to stay alive and then to communicate verbally with others, we need a good airstream. But what happens around our lungs as we age? What houses our lungs to keep them safe? Our rib cage, right? And those rib cage, or the ribs, are part cartilage. As we age, cartilage begins to ossify. Starts around our 3rd decade of life, right? So what does that mean for this rib cage's flexibility as we get older?
Decreased expansion.
Right, decreased expansion, absolutely. Less flexible, decreased expansion, meaning we can't get what? A good deep breath, maybe. That's exactly what can happen. So, now, for us, we might recognize that as running up a flight of steps. I'm not running, but by the time I get to the top, I might be a little out of breath. And what's going to happen when I'm talking? Yeah, I might only get 2 or 3 words out at a time, panting. So, your older person, my grandpa, to me, he sounds like he talks just like I do. I don't recognize it, but he recognizes that he can't breathe as well. Just part of nature. He's 90 years old, but he's very strong. So we move up then from our respiratory system, and we're going to go through this phonatory system. This is where our larynx is, and what is in here? Our vocal folds. So now, our larynx is composed of cartilages, other tissues, our vocal folds. And what do we say about those cartilages? As we age, they start turning to bone. They're ossifying, going through that process. So that means that they're not going to move like they should, right? Then on top of that, you have muscles that are doing what as you age? They're getting weaker, absolutely. That's what your vocal folds are. They're muscles. They're getting weaker. When muscles get weaker, your vocal folds, what do they have to do? They have to come together, right? So they may not come together as well in order for you to have a loud voice. Okay, we'll keep going. Then we're going to go up through our resonatory subsystem and straight to articulation. So we'll talk about those together. When we're talking about resonation, have you ever heard anybody who has like that thin voice, kind of reedy? You know what I'm talking about? I really can't make one. But you have people who have full voices, and they're able to project that voice. Then you have others that are very thin. Yeah, that are very thin and unable to. So when you think about your person in the nursing home, the long-term care facility, outside of maybe not having adequate breath support, or their muscles atrophying, if they cannot project their voice and you have someone who's in a great big hurry, do you think that they're going to wait around and ask twice for an answer? They're just going to go ahead and do what they think is best. Okay? And I see it all the time. Then we get to the articulation. What is in your mouth that helps make sounds? The tongue. That's your principal articulator. That's what we call it. It is a bunch of muscles. Okay? Now, what do we say about muscles as we get older? They get weaker. So you have somebody too who may, depending on what other disease process is hitting them, you may find that their speech is not as succinct or as clear as it could be. So that's what we're kind of dealing with. In the normal aging process, this person, without any other disease affecting him, that's my grandpa. He get along just fine. But then you overlay those diseases, COPD, dysarthria, cerebrovascular or CVA happening, anything else, and that it could cause all of this to suddenly become a huge issue. All right, so we just talked about the structural changes that you can expect and their consequences. Muscle atrophy, cartilage ossification, edema. Y'all know what edema is? Okay, that's swelling. Demyelination. When that myelin sheath up in our brain starts getting attacked, or it starts, my sister has MS, so I already know what's going to happen with her. But she's going to expect slower response times. You know, you have patients, you have to teach them safety awareness. They lay their hand on the stove and their reflexes don't immediately happen. They've burned themselves. So you're watching out for all of this for your patients. So our consequences: accuracy, speed, range, endurance. That range might have to do with loudness, How loud can you call for help? Might also have to do with, does my emotion or does my voice match my emotion? All of this you can think of for range. Endurance. Can I sit there and have a conversation without getting tired, by the end, so that now my voice is almost non-existent? Coordination, stability, and strength. So you can see here some of the speech impairments that you might see in these patients with compromised systems. Now we can talk about medication and dentition. I find that my patient on certain medications, I want to know when they're getting them and how long it is before their system or before they tend to react to it. Because if my patient has fallen asleep, then what is the therapy doing for them? Right, they're not even answering my questions appropriately. Okay, then I have other patients, especially going through chemotherapy, radiation, or what does that do for their eating? You can't smell the food, you lose your appetite, and that's what I see some of these patients doing. And then what are they at risk for? Yeah, weight loss, maybe malnutrition, absolutely, if there's nobody watching them. So we're trying to cure them of this and maybe causing this over here if we're not aware of it, right? Sensory disturbances, taste, smell, hearing, vision. We'll talk about vision in just a moment. Dysarthria and apraxia are both motor speech disorders. Are y'all familiar with them? Have you seen patients with either of these? Dysarthria, I often see it after a stroke, but there are other diseases, Parkinson's disease, Huntington's disease, where we expect to see dysarthria with those patients. Dysarthria basically is an underlying weakness. Now, how it presents itself is varied. The one that I see most often is a flaccid dysarthria. So the tongue is not really doing or not reacting as strongly or as crispy as maybe it does for us. So that patient can be really hard to understand. There are some things that the speech-language pathologist can definitely teach this kind of patient to help them. Among those is over-articulation or other ways to communicate as well. But dysarthria can be, for that patient, just as strong as or hard as the apraxia is for your other patient. The one with apraxia, what's happening with him is he knows what he wants to say, but he can't say it. His tongue, teeth, cheeks, everything, it's not moving the way that he knows it needs to move in order to produce the correct word. And this patient, I just had one, he was only 50. A very young man, of course, did not want to live in a long-term care facility. That's what happens with some of these individuals. So it's really important that for you you're maybe giving medication, right? So you need to be asking him questions about his pain and how the medication might be affecting him, or knowing that he is understanding the instructions that you're giving. But he might not be able to tell you or ask you his questions because in severe cases, he just can't get it out. For many patients, and my grandpa would be one of these because he had asked me a question recently, and his was about his voice. And he said, I just didn't know that anything could be done about that. I thought it was just part of normal aging, and that's what happens. A lot of these patients won't tell you these things because they just think it comes with age, that it has to be there and there's nothing that can be done about it. All right, I'm going to give you a chance to read this. You don't need me to read it to you. So what's that saying? Who's at risk for a voice disorder? Mm-hmm. Yep, that's the highest. Any group can be at risk, but they're showing that your adult males 70 years of age or older at the highest risk. They're most likely to experience that disorder. And unfortunately, what we see for many of our older men, all they want to do is make sure they don't have cancer. And then they don't seek out any other treatment when it might be available to them. So that's something you can help encourage. Okay, this is something, I can tell you what my psychology professor would say. He would say that it has to do with the chromosomes. Because they have an X and Y chromosome, they don't have the extra, I don't know, from our double, I was trying to, how did he explain it? That one theory is that they don't have that extra protection because they have different chromosomes from females. I don't know that there is actually, that anybody actually knows. Just seems like with a lot of the disorders that we study and that we run into, it's the men who have the greater likelihood for most of these, of either getting them or maybe not surviving them. So, listeners perceive older speakers more negatively than younger speakers, particularly on competence dimensions. Why do you think that is?
It's just society.
Society?
Yeah.
Mm-hmm. Older people maybe aren't perceived as strong, right? Maybe, the way that we talk as it becomes a weaker sound even, something in us makes us think let me help Grandpa over here. Maybe he's having some financial trouble. He can't budget as well as he could, or he responds slower after a question is asked, or any of this, and that goes back to competence. I hear, if you read that first bullet, I hear that a lot. They get tired of being asked to repeat themselves. People with hearing loss, okay? Your older person who has not dealt with it his whole life. He's tired of it. He doesn't want it to happen anymore. Just don't talk to me. I'm fine. I'm going to stare out this window. I see this a lot. And then I'm the listener, right? I start feeling bad for asking them to repeat themselves. I do. About the third time I don't want to ask. And so it is such a, suddenly I have this desire just to pretend like I understood and move forward. And that's what we have to watch out for. Now these right here, the increased pitch of the male voice, decreased pitch of the female voice, this has everything to do with those cartilaginous structures and the movement of the larynx. All right, for the female, it's getting lower because the larynx is lowering within the neck, so we're sounding deeper. The male, his raising just a little bit, so that's why his pitch is sounding a little bit higher. Plus, there is the problem with the muscles atrophying, right? Pitch range more restricted, can become more monotone, or you might see pitch breaks, right? Parkinson's disease, you're going to have a patient who does exhibit dysarthria, and one of the characteristics is that monotonous voice. The problem with the monotonous voice for that person is that he maybe can't say what he needs to say with the right emotion. Okay? And then you start thinking about, well, that's not a big deal. What if he has family? He's trying to communicate with his wife or his kids. All of these things affects the quality of life for the patient. Decreased loudness. As those muscles atrophy, they may not come together as well. Well, your vocal folds have to close in order to be able to build that subglottal pressure so that you can increase the volume of your voice. So the range, the variability of the loudness is affected, poor voice quality, and these are some conditions that can lead to presbyphonia, which is an older voice disorder, or a voice disorder that affects older people, presbyphonia. And certainly the diseases that can lead to it as well. So if you have patients who, that you're even concerned about, certainly holler at the speech language pathologist in your building. See if they can help the patient to deal with it, either identify it and work out strategies, or just to, just so y'all can talk about it together to see what you can do to better understand your patient. All right, now I've got 2 clips that were given to me of patients here at UAMS, starting out with voice problems and then afterwards what might have been done to help them with those.
Are there certain situations where it's worse, like crowded, noisy rooms, or on the phone, or anything like that?
No, I don't notice it on the phone as much as I do in just conversation. If I come and read something like this paragraph, I always have trouble. And in a class of some kind, if you're asked to read, I just know I can't do it.
Because your voice gives out.
Just give a story before I finish.
Okay, all right. Do you hear a shakiness in your voice, a tremor? Okay, hold out an E for me. E. Good, do that again. E. Okay. Anything else you want to tell us about your voice?
Nothing I can think of, it's just breathlessness sometimes.
On a scale of 1 to 10, with 1 being not feeling handicapped at all, and 10 feeling really handicapped by your voice, what number? 8. Okay. All right. What makes it an 8? What one thing makes it an 8?
Just not having control of my voice.
Excellent. Thank you.
All right, so did this lady's voice sound any different than you would expect it based on looking at her picture? No, sounds normal. Sounds normal for looking at this sweet older lady. You expect it, but how did she feel about it? She said she was embarrassed. She had no control over it. A big thing that we all watch out for is what something like this can lead to. You're embarrassed about your voice. What might you do eventually? Withdraw. Social isolation. Maybe she's not going out or wanting the family to go out to a crowded restaurant because she can't talk and be heard. Okay? Anything. So there are things that can be done to help her with that. Certainly, we can't do anything about the muscles atrophying, but there are other strategies that can be put into place to help her. Let's go forward and see, because I think there's one in here. In just a little bit, we can talk about her again. All right, now we have this gentleman. He's complaining also of a weak and breathy voice.
I have to force conversation. And the more I talk, the worse it gets.
Okay, so his voice. How about for this gentleman? Would you expect that kind of voice? Mm-mm. So we kind of forgive Grandma just a little bit more. We expect that. We think it makes her sweet. But this gentleman, he's going to have, especially if he's working, right? He might be overlooked. I had a woman who broke down and cried on me one day, said that her career was over because of her voice. So this gentleman, he complains about that weak and breathy voice. And he says that he just can't. What did he say? Let's go back and listen to that again. There was something I wanted to. It was a short one.
I can't talk out of I'll get enough breath to make it work.
It's real soft.
It's real soft. Now I have to force conversation. And the more I talk, the worse it gets.
So, and he's talking about how he has to force the conversation. The more he talks, the worse it gets. If you're forcing it, that could lead to further voice problems. You can end up creating muscle tension dysphonia. Then we've got something else that has to be treated. All right, this was from the gentleman, and let's see what his vocal folds look like. See how it was lower than the other one? So not only I don't know, maybe he's dealing with some muscle atrophy, definitely, but there's paralysis there. Okay. Now let's see, after they did some voice therapy with him.
The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch, which is half high above, almost this up, and its two ends apparently beyond the horizon.
Give me a nice loud
I couldn't do that at all before. No
Is
way.
that right?
So he sounds a little bit happier, right? Sounds like he could be forceful in the workplace, all right? But let's talk about the voice therapy real quick. He had some paralysis. We can't fix that. But there are strategies that can be used to help him. Now, he got a whole lot better volume there. So there are surgical techniques that can also be used. He might have had something inserted, some kind of wedge or something to help bring those vocal folds together. There are other things that can be done in addition to that, just environmental changes that can be made so that he can sound better like that. In the end, though, he's happier. All right, now we're talking about visual effects. Do you really think of visual effects affecting communication or vision affecting communication? How could it affect communication? I had a little old lady dealing with macular degeneration, and I would walk into her room, and she wouldn't necessarily look at me when she talked because she couldn't always find where I was. And then she had a soft voice on top of that. So I'd have to ask her to repeat herself. One of the things that I teach and that other SLPs will teach patients who have difficulty projecting their voice is to look and maintain eye contact with the person that you're trying to talk to. Okay, but in my little lady's with her problem, she couldn't even see the person, where they were. And then if you have a CNA walking all over the room at the same time talking and asking questions, now we've really got a potential communication barrier, right? So vision can absolutely, plus then you've got, if you add a hearing problem to this, which by the way she had, you can't write notes because you can't read them. You know, so now you've compounded the problem. And this is why vision, you have to be aware of their visual status as well. And then swallowing difficulties or dysphagia with communication. This is the primary thing I get called in for is swallowing. At my facility, I do all the swallowing, the bedside studies for this, but this is just going to compound that problem, especially when you have to look at changing a diet or ordering more a visual, because maybe the patient doesn't realize that he's having problems with eating. There could be silent aspiration, any of this. So you don't think about it necessarily as communication per se, like speech, but just knowing what might be going on with this patient. Okay? Now we'll get back to the rules of communication. I think this is it. So if you read through these and you think then about these older people, maybe after everything that we've talked about, they'll mean something a little bit different to you.